Welcome to video series on acid-base balance. Here is a quick summary of metabolic alkalosis. The main defect, biochemical defect in metabolic alkalosis is loss of acid or excess of bicarbonate or excretion of acids. There are two types of metabolic alkalosis. One is chloride resistant and the other one is chloride responsive. Now the chloride resistant metabolic alkalosis is characterized by increased reabsorption of bicarbonate resulting in extracellular fluid expansion or ECF expansion. Two important causes for increased reabsorption of bicarbonate with ECF expansion include the Cushing's disease and Cohen's disease. In Cushing's disease, there is increased synthesis and secretion of glucocorticoids and mineralocorticoids, resulting in increased sodium reabsorption and increased hydrogen ion excretion. So this leads to loss of acids and metabolic alkalosis. In Cohen's disease, there is increased aldosterone causing increased sodium reabsorption and hydrogen ion excretion, leading to loss of acids and metabolic alkalosis. The other causes for chloride resistant metabolic alkalosis include the antacids, especially the consumption of absorbable alkali. This increases the bicarbonate, leading to development of metabolic alkalosis. The other syndrome is milk alkali syndrome, characterized by excessive intake of calcium carbonate. Now this milk alkali syndrome is characterized by a triad of hypercalcemia and metabolic alkalosis because of consumption of absorbable alkali in the form of calcium carbonate. Now this hypercalcemia causes renal vasoconstriction, decreases the GFR, and this can predispose the patient to development of renal failure. So these are the causes for chloride resistant metabolic alkalosis, and this is characterized by urine chloride excretion of more than 10 millimoles per liter. The other form is chloride responsive metabolic alkalosis. Here the main characteristic feature is loss of acid resulting in ECF contraction, and the causes include the loss of acid can be because of loss from GIT, severe vomiting, nasogastric aspiration. In all these conditions, there is loss of acid resulting in metabolic alkalosis. Renal loss in the form of use of diuretic drugs results in loss of H+ ion and leads to development of metabolic alkalosis. Chloride responsive metabolic alkalosis is also characterized by paradoxic aciduria. This is because here there is loss of acid or the fluid results in volume depletion, which activates renin, angiotensin, aldosterone system. Now this aldosterone stimulates excretion of hydrogen ion and potassium ion in urine and makes the urine acidic. So in metabolic alkalosis, especially the chloride responsive metabolic alkalosis, the blood pH is increased whereas urine pH is decreased. This is because of paradoxic aciduria. And here the urine chloride excretion is less than 10 millimoles per liter. Coming to ABG analysis and the electrolytes, in metabolic alkalosis, the pH is increased, bicarbonate is increased, and partial pressure of carbon dioxide is normal. Now, alkalosis is characterized by hypokalemia. This is because of redistribution of hydrogen ion in exchange of potassium ion. In metabolic alkalosis, what happens is there is increased bicarbonate ion, and so what happens is, in order to maintain the cation concentration, hydrogen ion from the cell moves into the bloodstream and potassium moves inside the cell, resulting in hypokalemia. Next, metabolic alkalosis is characterized by hypocalcemia. This is because now the binding sites on the albumin are free, so calcium goes and binds to albumin, and this decreases the blood calcium, resulting in hypocalcemia. The next disturbance is hypochloremia. This is because in metabolic alkalosis there is increased concentration of bicarbonate. As a compensatory mechanism, chloride decreases, resulting in hypochloremia. Coming to compensation of metabolic alkalosis, we know there are two rules for compensation. Compensation involves the counter variable, that is rule number 1. Then the second rule is compensation always involve in the same direction as that of the primary variable. Primary variable in metabolic alkalosis is bicarbonate, which is increased here, and the counter variable is carbonic acid, and this also has to increase to compensate this metabolic alkalosis. Now this bicarbonate is increased by hypoventilation, by respiratory system or the lungs, and the renal system contributes to compensation by excreting the bicarbonate when the pH is more than 7.5. This is how the metabolic alkalosis is compensated. So this was all about metabolic alkalosis quick summary. Next video will be on respiratory acidosis. Thank you. Please do like, share and subscribe.